The role of
Yes.
the role of chemotherapy alongside the hormonal treatment in the metastatic hormone sensitive prostate cancer. Next slide, please. So there is the benefit of the chemohormonal therapy we discussed in the metastatic hormone sensitive prostate cancer, high volume versus low volume disease is there. Then there is the androgen receptor pathway inhibitor in combination with docetaxel in the management of metastatic hormone sensitive prostate cancer, HSPC. Choosing between in the 2021 guidelines, there are the docetaxel and androgen receptor pathway inhibitor in the metastatic HSPC. Now there is the role of doublet and triplet combinations also, and utility of PSA also. And there are the ongoing phase 3 trials of editing metastatic HSPC. Next slide, please. So this is the first slide of the chemohormonal therapies in the metastatic hormone sensitive prostate cancer. Next slide, please. So they are the OS results from phase 3 trials of editing the CSPC trials. They are the many trials about the charted, Stampede, Latitude trials, all about the docetaxel chemotherapy, and then there is the ARPIs. They are the Titan, Arches, and Enzyme trials. They are all about the sensitive prostate cancer. So it is better to understand all about the ADT with ARPI with the chemotherapy. Now they are the combination therapies, the doublet or triplet therapy about this, and the docetaxel alone also. Next slide, please. So there are the major trials are the charted trials, high volume versus low volume disease. They are the median follow-up around 53.7 months in metastatic hormone sensitive prostate cancer. This is the ADT plus docetaxel is around 51.2 median OS is there, and in ADT alone is only 34.4 in the high volume disease. Next slide, please. And this is the another trial of the docetaxel chemotherapy. Get GTUG FU15 trial, high volume versus low volume disease is there, and again there the median dose overall survival is more with the ADT plus docetaxel. It is 39.8 months. In the low volume disease, there are the ADT plus docetaxel is 69.5. It is not reached this there. Next slide, please. And this is the third trial. That is a Stampede trial. It is various arms. One arm is there with docetaxel. Next slide, please. So interpretation of these three trials are the volume status does not relate to sensitivity to docetaxel, but there are the two trials. One is the charted and second is the K2G AFU15 trial. They said could separately differ the treatment with docetaxel until the progression to CRPC. So they established the treatment of the chemotherapy docetaxel in high volume disease. Then there is the Stampede trial that benefited the early docetaxel regardless of volume status. So hypothyroid related to greater number of patients with de novo rather than the recurrent disease in Stampede, and they benefit from the docetaxel in low volume as well as high volume disease. Next slide, please. And there the androgen receptor pathway ARPIs in the combination with docetaxel. They are the combination therapies and with the ARPI with docetaxel in management of mHSPC. Next slide, please. So there are the three trials, Titan, Arches, and Enzyme. In all the three trials, there are the few patients who received the prior docetaxel. So in the Titan, there are the ADT plus apalutamide, then the enzalutamide, and Enzyme also for the enzalutamide with ADT plus enzalutamide. It is placebo in the Arches trial, and Enzyme trial it is the non-steroid androgen inhibitor are there. Next slide, please. So this is the Titan trial. Apalutamide is also showing the benefit in the OS, final OS trial. So there is the prior docetaxel in the 28 patients, and it is not reached there the apalutamide. OS is median OS is not reached, and in the prior no there is the 48.7 months without the apalutamide. Next slide, please. Next slide. This is the Arches trial. There are the low volume disease, high volume disease, no prior docetaxel, and the prior docetaxel. So it is also show there around the 24 months also, 36 months also, and 48 months also. So with the docetaxel, they are prior received, there is the more survival advantage. Next slide, please. The same is the Enzyme trial also. Next slide. Next slide. So there This is the guideline. They are the choosing between the docetaxel and ARPI in the metastatic HSPC. Next slide, please. So this is the Stampede trial. They are standard of care with abiraterone acetate or standard of care of with docetaxel and prednisolone. So next slide, please. So in the board, they are the favors the standard of their overall survival is fair the docetaxel and prednisolone arm. Next slide, please. So there are the in the abiraterone arm, we see the 82% is prostate cancer and 80% are the death causes are other than the prostate cancer. Next slide, please. So according to these all trials, next slide. Now there are the doublet therapy for the HSPC. All eligible patients should be offered treatment intensification upfront. And choice of agents are the, as we prior seen, docetaxel, abiraterone, apalutamide, and enzalutamide. So there the docetaxel is available, abiraterone is available, enzalutamide, and the apalutamide. Subgroup analysis from Stampede also support the RT2 prostate in conjunction with ADT for low volume disease. Next slide, please. And next slide. So this is the new trials out there. The piece 1 trial, piece 1 is amended to allow for evolving the SOC. And docetaxel as a stratification is used there. Next slide, please. So piece 1 trial is there. The PFS on OS with abiraterone with the docetaxel plus minus radiotherapy in the population is there. So SOC is docetaxel with abiraterone. There is the P value is the less than 0.001, and there with the abiraterone there is the PFS is more and OS is there. Next slide, please. So OS with this metastatic burden is high or metastatic burden low. So there first trial for the abiraterone in conjunction with docetaxel. Next slide. And grade 3 to 5 reported in editaxel and docetaxel. They are the main difference in the only one thing is there. If the abiraterone and docetaxel both are used, then the liver side effects are more around 20%, 6%, and in the only docetaxel only 2%. This is the only side effect which is more seen in the combination therapy. Next slide, please. So addition of abiraterone to standard of care ADT plus minus docetaxel significantly prolong PFS, different PFS and OS also. No evidence of differential benefit with the ADT alone versus the ADT plus docetaxel alone. Well tolerated only for the elective abnormalities. Next slide, please. This is the second trial, Erasmus trial. There are glutamide in mHSPC. This is a new drug. There are the docetaxel with darolutamide and ADT plus docetaxel with placebo. And primary endpoint is overall survival. Next slide, please. So primary endpoint with the overall survival, addition of this darolutamide to ADT plus docetaxel significantly lowered risk by the 32.5%. Next slide. So OS benefit treatment intensification is there. The docetaxel is there. Then the charted is Stampede. Then the abiraterone plus docetaxel, and last is the darolutamide plus docetaxel is there. And hazard ratio is 0.62 to 0.68. Next slide, please. And this is the 7-month PSA. This is the prognostic marker that is marked in the charted trial. Next slide. OS benefit for adding to abiraterone or newly the darolutamide to ADT plus docetaxel does not address benefit of adding to docetaxel to ADT plus ARPI. And they are the adaptive process for both the therapies. Next slide, please. So now those 2021 treatment, there are the treatment guidelines like the ADT plus one of these abiraterone, apalutamide, enzalutamide, or docetaxel. Next slide. And now in the 2022 with these data, they are the patient with metastatic castration sensitive prostate cancer, ADT plus if chemotherapy is not preferred. Why? They are the consideration like the chemotherapy fitness, symptom burden, cost, low versus high volume diseases, histological, morphological features like poorly differentiated genetic features, and GEP is also there in the data in the 2022. There are the option of abiraterone, apalutamide, or enzalutamide, or nonmoving darolutamide. And if chemotherapy is preferred, There is the data of the docetaxel plus abiraterone or docetaxel plus darolutamide. This is the GSS 2022 data, along with the denosumab every 6 monthly or zoledronic acid, only for the patient with the 10-year risk factor more than 3%, not for the all patient in the CSPC. Next slide, please. So there is the data for the docetaxel previously also for the signal therapy, now with the doublet therapy also, and local therapy to primary and RT to oligomers with the like the stampede foil source. Sorry. Next slide, please. They are the ongoing phase 3 trials. Next slide. They are the Aeronet, keynote with the pembrolizumab, sorry, and with the abiraterone also. Next slide. So now there are the in the docetaxel arm there are the no data about the nano-equally formulations, but they are approved in the breast and they are coming in the prostate also. So something like conventional taxane formulations, organic solvent is there. So there is the hypersensitivity reactions. The grade 3 and 4 hypersensitivity reactions are not a major concern in nano-equally formulations, and adverse effect due to the steroid remedications are less. And neurotoxicity, there are no data, but there is equivalence in the convenience and nanoequilibrium in both of them. This is the also there are the in the CSPC we use the hormonal therapy with the chemotherapy, and chemotherapy arm is better in the high volume disease with the combination or alone. Next slide, please. So conclusion is there that the treatment intensification in metastatic hormone sensitive prostate cancer is associated with OS benefit and should be offered to eligible patients only. And in patient plan to the upfront docetaxel, we can add abiraterone or darolutamide if approved as a triplet therapy is associated with the ADT. So it is triplet. It is associated with OS benefit, but optimal patient selection and timing is unclear now. And quality of life and patient preference must be considered because they are the castration sensitive patients. Before treatments are selected and administered to this patient, administered to these patients. So this is the new guidelines about the chemotherapy along with the hormonal therapy in castration sensitive or hormone sensitive prostate cancer patients. Next slide, please. Thank you so much.
With the permission of chairperson, can I ask a question?
Yes, sir.
Yes.
So I couldn't understand this triplet therapy. Is the combination upfront of the dosi with the abiraterone, or it is the sequential is preferred that you give first 6 to 9 cycles of the dosi followed by abiraterone in continuity?
Sir, it is the mainly the docetaxel with the ADT and then the abiraterone, sir. Triplet therapy.
So it's a sequential treatment.
Sir, in the trial, it is so that there are the concurrent treatment also with the abiraterone.
Can you go back to the slide, Sudhir?
Yes, sir.
I think it is concurrent. Can you show the slide? Because
yes, sir. In the trial, it is. Kindly go back for the sir. I am not control. Kindly go back for the slide.
Can someone go back to the slides? Suruchi, can you go back to the slides?
Go back, sir. 3 to 4 slide prior. Kindly go back. Kindly go back. One more, two more. One more. One more. One more. One more. One more, which is the development medicine. One more. One more slide. One more. One more slide. One more slide.
Yeah.
This is the sir abiraterone, 100 mg per day plus prednisolone, or this is concomitant to docetaxel. And with the radiotherapy, with the standard of care, this is the docetaxel with the prednisolone. And second arm is abiraterone plus isocic. Next slide, please. Next slide. Next slide. Next slide. Next slide. Next slide. And this is also docetaxel 75 mg plus darolutamide, they are both are the concurrent therapy for the triplet therapy with the additive.
Right. So all the drugs are given together from virtually day
Yes,
one.
sir. Yes, sir. Only with the placebo is the second arm.
And it's a 28-day cycle.
Yes, sir.
Okay.
So,
not
Harish, if I
21
can
days.
add,
It is the
that,
phase 3 trial, sir. It is newly coming in the 2022 only, sir.
actually, the triple drug is in the peace trial where you have ADT plus the docetaxel plus the SOC, which is there. Along with that, radiation can be given or cannot be given. They didn't add radiation as a confounding agent because it was found that radiation, whether given or not given, it was not causing a bias in the final outcome. So
Yes, sir.
triplet therapy was all the three drugs which were combined.
Concurrent.
Compare it with the doublet therapy, there was a increment of about 10 months as far as the survival was concerned, whether it was abiraterone or enzalutamide in the doublet versus the triplet.
Yes,
Then
sir.
you
And
require very fit patients whenever you give the triplet therapy.
yes, sir. Because it is a hormone sensitive for prostate cancer, so they are the de novo. They are the general condition is good, and they are we can easily use in this data for the patients.
Sir, only thing is enzalutamide probably should not be used. Maybe what we have to extrapolate from the data, we have Arachis and Enzamate. Although Enzamate in some on day one high burden disease that might have shown, but sir, for all practical purposes, if we have to give a triple drug, it should either be a abiraterone or darolutamide.
Yes, sir. Yes, sir.
That
Next
is
slide,
all.
please. Next,
Again, I'll add here, Bharat.
next slide, please.
There was a post-hoc analysis in which it was found that when you add enzalutamide to docetaxel, it was counterproductive.
Okay,
Sir,
sir.
Yeah, that is exactly what.
Next slide, please.
And that is why abiraterone was being used.
Next slide, please.
Right. So I think the final thing which I'd like to add, which he showed in one of his slides, was because the role of drugs like zoledronic acid or denosumab is not established in patients with HSPC.
Yes,
But I
sir.
think, can you go to the next few slides? When you have to choose between the...
Yes, sir. Kindly forwards.
Yeah. One more slide, please. Next.
One more.
Next.
One more. One more.
Next.
One more. One more.
All right.
Yes, sir. Yes,
So
sir.
I think this is where it reads denosumab or zoledronic acid, but
All
then
right.
this is given virtually, at 6 months or 1 year interval for patients to prevent osteoporosis or the risk of fracture.
Yes, sir.
So I think this remains the same. So we should not be using these bone modifying agents on a monthly basis,
Yes, sir.
as is done in patients with CRPC.
Yes,
So I
sir.
think that is another important issue which we should take home.
Yes, sir. It is only in the Stampede trial. It is also established that this zoledronic or donazumab or alendronate is not used in the CSPC. First thing is in Stampede. Then there is the now it is in 2022. There is the only osteoporosis changes are there. Then we can use. And sir, in the guideline there are the only two are the docetaxel plus abiraterone and now the darolutamide and some data of enzalutamide also, sir. If the chemotherapy is preferred for the patient.
Right. So I think the current NCCN guidelines for, I would say, in practical situation, if you have a relatively young, fit person with high volume disease, one can consider using a triplet, which is, something like either, injection of LHRH agonist or antagonist along with abiraterone and docetaxel. So docetaxel can be given for about 6 cycles, 6 to 9 cycles, and then abiraterone should continue.
And yes, sir, and new data with the darolutamide in the 2022 GUCS, sir.
Yeah, so darolutamide data is, I think, coming up very strong.
Yes,
So
sir.
I'm sure in the next few months, you will get that information, and maybe that gets included in the NCCN guidelines as well.
Yes, sir. Thank you so much, sir.
Right. So I think with this,